I'm Peter Block here in Chicago at ACC 2016, and this is the total, big time, all things wrap up. I'm here with Deepak Bhatt, my friend who has done this and knows everything about all clinical trials that were ever done. Deepak, let's start with Stampede. You were involved with Stampede
right.
as a co-PI, so tell us about that one very quickly. What do you think, not necessarily about the details, what does it mean for the folks out there?
Sure. So, I'm partial to it, of course, but I think it's a terrific design because it did in bariatric surgery what we commonly do in cardiology. That is, apply randomized clinical trial design. So there have been a lot of data previously showing that bariatric surgery was terrific. It causes weight loss, of course, that it improves diabetic control, that it's associated with lower mortality. But that's all observational data. So we did a randomized trial, 150 patients, not easy to do these randomized surgical trials, and found that bariatric surgery versus best medical therapy in patients with diabetes actually caused resolution of diabetes in a pretty high percentage. We'd reported that before as a late breaker at ACC, but these are the 5-year results showing durability out to 5 years.
This is big time, and it's two different kinds of surgery too. They both seem quite effective.
That's right. One's the classic Roux-en-Y, the big deal. The other's a sleeve gastrectomy, laparoscopic surgery, and both look pretty good. There were some subtle differences between the two. It might be that invasive is a little bit better for some parameters, but overall a win for bariatric surgery.
Absolutely, big time win, and that was day 3. But let's go back. Let's go back to, if I were to ask you,
go back in time.
Let's go back in time. That's right. What was the thing that really struck you as being the most important trial out of this meeting? Hope. I think hope probably
would have
wins.
to say hope, just because it was a 2-for-1. That is, there were two important hypotheses being tested in patients who were rather intermediate risk, I might even say kind of lowish risk for the sort of patients we're used to dealing with, that statins work, so confirmation, further confirmation, extension of statins and their benefits, and that blood pressure lowering, unless your blood pressure is high to begin with, doesn't clearly work.
The good news about this, though, is it seems to me that maybe some bad news, too. Some of the folks out there have said to me, big deal, we were treating these patients anyway, right? They're intermediate risk patients. They all had some risk, and we gave them a statin, and that seems like a reasonable thing to do. How do you counter that?
Well, first of all, a lot of people say that, right? When a trial is negative, they say, oh yeah, I knew that was going to be negative. When it's positive, they say, oh, I was doing that anyway. So 99% of the time, that's not even true. But with statins, there's been a lot of controversy and a lot of discussion out there about who to treat. Should we be treating low-risk patients? What about side effects? Is it worth it? Should they really be in the water, et cetera? And I think this shows that in a patient population lower risk than we'd previously been routinely treating, and one that's relatively easy to identify, that statins reduce cardiovascular events. So I think it's a big deal.
Yeah, okay. So now we're talking about statins. I've got to bring up this whole business of muscular aches with statins and that trial, because this is really sort of cool, right?
Yeah. Well, I think, it was a carefully done trial, Gauss 3, you're referring to, that Steve Nissen had led, and the trial showed that myalgias really do occur. And it's a glass half full, half empty sort of deal. Some people said, oh yeah, it's such a low rate in a carefully selected population, but I actually looked at the other way. That is, there are some people saying, oh, the statin myalgia stuff, it's not real. Oh, the companies are making it up to sell PCSK9 inhibitors and other new drugs. This trial shows that statin myalgias are real. Yeah, it's maybe not everybody, but sure, there are some patients in a placebo-controlled blinded trial that really do have myalgias with statins.
I think that's a critical point, and we always sort of said, oh, poo-poo, and candidly, I raise my hand and say, I was just as bad as some of those other guys.
Well,
but
I wasn't,
because
you see these patients in clinical practice, and sure, some of them, you give them a placebo, they also have myalgias, but some of them, it really is the real thing.
It is. So important to remember clinically, and now proven, and let's move on from that myalgia business.
Absolutely.
The PCSK9 inhibition is going to be a big deal as well. We'll find out how all that works out going forward. Okay.
Absolutely. Chris Cannon presented some interesting data here. Post hoc analyses out of Odyssey, which is one of the PCSK9 inhibitor programs, showing that with PCSK9 inhibition, even really low LDL levels under 50 seem to be associated with a reduction in MACE. Underpowered post hoc, but still potentially a signal of what's to come from the large outcome trials.
And Bob Vogel has always said, your LDL can never be low enough. So we'll see how all that works out, but very interesting data.
Yeah, very interesting.
So there you have it, important trials, very important data, even for the guys that are out there in little clinics taking care of patients with high cholesterol and giving them statins and wondering about the muscle aches.
That's right.
Thanks very much, Deepak.
Thank you, Peter.